My name is Rajiv, and I'm one of the interventional fellows at the University of Chicago Medical Center. My mentor for this case is Dr. Atman Shah, and I'll be discussing a case of percutaneous transapical closure of severe paravalvular mitral regurgitation. Here are our disclosures. So the case starts off with a 42-year-old female. She has a history of congenital bicuspid aortic valve disease, aortic regurgitation, and recent endocarditis requiring mitral and aortic valve replacement. The patient is now presenting to your clinic with symptoms of dyspnea on exertion and fatigue 1 month post-op. She comes in with a transthoracic echocardiogram, and in panel A, you can see that there's abnormal motion of the bioprosthetic valve. Sometimes this motion is described as rocking. It's additionally important to note that the bioprosthetic mitral valve leaflets do not appear thickened or degenerated. They appear thin and pliable. And in panel C, we see that there is an elevated diastolic mitral valve gradient in the absence of mitral stenosis. The patient was then referred for transesophageal echocardiography. And in this case, you can see that there is severe paravalvular regurgitation. And the location of this appears to be on the posterior lateral border of the implanted mitral valve. You can see that regurgitation right there on the panel on the right. To further characterize and identify the location, we used 3D imaging. And this is actually an example of 3D TEE imaging using a software called Transillumination, which allows better depth and tissue characterization. These pictures actually allowed us to identify the defect location and then further characterize the actual size of the defect, which appeared to be approximately 6 millimeters by 2 millimeters. And we've identified the location being at the 6 to 8 o'clock position from the surgeon's view. In this view, we're actually looking up at the mitral valve from the left ventricle, and we'll explain a little bit more about the surgeon's view later on. So after a multidisciplinary discussion, the plan was to proceed with percutaneous closure of the leak. Our plan was for transapical access, and for this, we used ultrasound to identify the trajectory. We used a micropuncture needle, and we placed a hemostat initially where we wanted to have our trajectory be. And then at this point, we performed a coronary angiogram to make sure that our trajectory would not interfere with or damage the left anterior descending artery. At this point, we placed a 5 French vascular sheath. And then through this, we placed a Headhunter H1 catheter, and we used a straight stiff glide wire to cross the actual paravalvular leak. We crossed, and in the panel on the upper right, you can see that the wire is across the defect with color flow adjacent to the wire. Next, we were able to swap out our glide wire for a Amplatzer extra stiff wire. And over this, we placed a 6 French torque view delivery system. You can see that we placed a device, and the device that we selected was a 6 millimeter Amplatzer ventricular septal defect occluder. We selected this device, which had a waist diameter of 6 millimeters, and it has outer disc diameters of 14 millimeters. This is key that we were able to size the device or select a device size based on the 3D TE images that we had shown earlier. In the bottom right panel, you can see the torque view device, which is in the left atrium with the left atrial disc deployed here or exposed here. Next, you can see that we're pulling the device back against the left atrial aspect of the leak. And you can see both fluoroscopically and on echo what that looks like. Next, we successfully deployed the device itself with our torque view being in the left ventricle. At this point, some people will just pull all of their equipment out of the left ventricle and allow the transapical access to seal itself off. However, in this case, we elected to place an off-label PDA occluder. The device we selected was a 6 millimeter PDA occluder, which has a retention skirt of 10 millimeters. And here in the bottom left, you can see that we're beginning to pull back on the PDA occluder with tenting of the 10 millimeter retention skirt here. Finally, we released the device. And after releasing the device, we then performed an LV gram to to confirm that there was no evidence of extravasation of contrast or blood outside of the device. Next, we repeated the transthoracic echocardiogram, and we found that there was no evidence of a pericardial or pleural effusion. There was a significant decrease in the mitral valve diastolic gradient to 4.5 millimeters of mercury from 10 millimeters of mercury initially. This is related to the decrease in blood flow across the mitral valve. On the short axis images, we actually saw that the bioprosthetic mitral valve leaflets did not appear impinged by the VSD occluder, and the VSD occluder appeared well seated without color flow across it. At this point, the patient was stayed overnight for monitoring in the cardiac ICU and was able to be discharged on post-op day 1. So a question that we have is this: a 75-year-old male with a history of mitral valve endocarditis requiring mitral valve replacement 8 months prior was admitted with anemia, dark urine, orthopnea, and dyspnea on exertion. The patient's transthoracic and transesophageal echocardiogram confirmed a paravalvular leak at the 2 o'clock position, and the patient underwent percutaneous paravalvular leak exclusion. So if we just start by looking at the stem first, this is a patient who's presenting with evidence of anemia, dark urine, likely hemolysis. They also have orthopnea and dyspnea on exertion, potentially related to the dehiscence and the regurgitation across the actual leak. The patient's leak was at the 2 o'clock position, and like I said, we're going to get to that in a minute because that's a key part to this question. Which left atrial pressure tracing reveals a potential complication from the aforementioned procedure? Option A reveals a normal atrial pressure waveform. Option B reveals a steep X and Y descent, which typically corresponds with constriction. Option C reveals tall A waves, commonly referred to as Cannon A waves. Option D reveals fusion of the CV, and we actually see an absent X descent. And this can sometimes be seen when there's mitral or tricuspid regurgitation. So like I alluded to, the location of the leak is critical. From the first case that we discussed, the leak was located at around the 7 to 8 o'clock position. However, in this question stem, the leak was at the 2 o'clock position. When we think about this in the surgeon's view is looking down at the mitral valve from the left atrium. So you're looking down at the mitral valve, and the area between the mitral valve and the aortic valve is typically termed the 12 o'clock position. To the left of the mitral valve is the left atrial appendage, and that's typically the 9 o'clock position. Now, this patient's defect was at the 2 o'clock position, which is near where the atrioventricular node is. And during paravalvular leak exclusion, the device placement can actually lead to complete heart block in some cases. If this happens, patients can have complete heart block, necessitating placement of a temporary pacemaker. And in some cases, if the device has not been deployed, it should be retrieved. In other cases, if the device has been retrieved, these patients may go on to needing permanent temporary pacemaker placement. So the correct answer in this case was option C, in which we see Cannon A waves, and this is potentially related to complete heart block, where the atrial contraction is occurring against a closed mitral valve. The final learning points I'll discuss with you are mechanical and bioprosthetic paravalvular leak is an uncommon complication that until recently required open heart correction. Transthoracic and transesophageal echocardiography are very helpful in this case. They can help diagnose and guide therapies. In this case, we saw that the actual TEE images helped us select a proper device based on the size of the defect. It can also help us identify where the defect is and then plan how we're going to access and cross that defect. Finally, it's important to think through what are the different options for crossing the defect. If you look at this figure here in options A and B, they actually perform a transseptal puncture and cross the defect in both of these. In option A, the wire crosses the defect and then goes out the aorta, while in option B, they cross the defect and the wire is actually snared out of a transapical access. Option C shows us retrograde crossing of the defect with a transseptal snare in the left atrium that snares the wire for additional support. Option D is what we elected to do for our case, where we did a transapical access, crossed the defect, and then deployed the device. In cases where additional support is needed or maybe larger equipment is needed, transapical access can be used. However, a transseptal snare can snare the wire in the left atrium and then provide additional support for larger equipment that may need to be brought in. Thank you again for your time, and hopefully this was helpful for you.